I'm going to briefly present here a case of a patient who has what is known as a chordoma, which is as Dr. Vivek sort of initially alluded to, a malignant type of sarcoma that's arising from the spine. This is a case that we treated here at the New York Proton Center. So the patient's history is he's a 63-year-old gentleman. He had a chordoma, as I alluded to, arising from the left portion of his vertebral column, primarily in the upper thoracic area. So in the upper sort of chest region, from T3 to T5 specifically. How this sort of arose and how he came about this diagnosis sort of dates back a few years. He originally was diagnosed actually with a colon cancer that was in August of 2018. And for that colon cancer, he originally underwent surgery, which is generally the standard way of curing colon cancers. He had a phenomenal surgery. At that time, there was no indication, no recommendation to get any other therapy for his colon cancer. But generally, for most cancers in the body, most tumors, you will tend to do additional imaging at the time that a tumor is diagnosed to make sure that that tumor is not found to be anywhere else, that there is no metastasis, as we've been talking about with many of our other cases. And in that process, the patient had a CAT scan done to make sure that his colon cancer was not anywhere within his chest, and it was not. But what they found on this CAT scan, and this does happen sometimes when you do imaging, is you find things that are incidental, things that are not causing the patient any problems or any symptoms, but they are something that you find when you start to do additional imaging and you start to look. What they found was in the upper left lung, a specific type of tumor. It's a very, very slow growing tumor and many times does not grow at all in a patient's lifetime, which can generally be managed by just observation. And that's what he was recommended for that type of specific tumor, is just observation. And for that type of tumor, he underwent additional imaging about a year later. That was summer of last year. And at that time, they found that the tumor was relatively pretty stable in the left lung, but a new finding had developed, and that was a new paraspinal mass that was of concern. For this paraspinal mass, and any sort of mass that arises near the spinal cord and the vertebral column, which is down the midline of the back, as I'll show in a minute, MRIs are very helpful. And really for any sarcomas, MRIs are the most optimal modality of imaging. What they found is MRI did confirm that there was a left paraspinal mass arising, as I mentioned, from the upper chest, upper thoracic area. But what was of most concern is that this tumor was sort of invading very significantly into the canal and pushing the spinal cord, as I'll show here on the next slide, at these regions. So I just want to sort of set the pictures here and set the context so everyone can understand. How you're seeing this is the patient is laying on the table. This is the back of the patient. This is the front of the patient. This is the left side of the patient, and this is the right side of the patient. And you're basically looking at individual slices going from the top of the patient to the bottom. And I've just shown 3 pictures, but obviously there's many more pictures in between. And one of the few areas that I want to show that are important are, this is bone here, and this is bone here as well. This is what's called the vertebral column. This is the column that protects your spinal cord, which is this region right here. And your spinal cord is a critical organ, as Dr. Srinivas mentioned earlier in our talk. It's a critical organ in that it serves a lot of function. It is highly important in obviously sensation and motor and strength of all of your extremities, including also control of your bowels and your urinary tract. I mean, it just serves a significant number of functions. And so it's an organ that needs to be protected at all times. However, as you can see, this was a tumor that was arising right here within the left portion of the paraspinal region. And on the second picture, you can see how it's pushing and sitting right next to the spinal cord. And so obviously that in itself can be very detrimental and obviously put the patient at risk of significant toxicity. So as you can see here from the pictures, this is sort of the degree of the tumor. At the time, the patient was originally seen by a neurosurgeon, and the recommendation generally for these tumors is to go in and take them out, especially because of the significant amount of cord displacement or the involvement of the cord. And that's what the patient had done earlier this year, a pretty extensive surgery which confirmed that this was a chordoma. They did a very excellent surgery, and actually on the post surgical MRI, which you can see here, there's really no evidence of any tumor. You can see that the spinal cord has sort of come back down into the midline here, which is where it should be sitting. And so this kind of raises that same question that Dr. Vivek had mentioned earlier, is why in this situation, when there's no tumor left after the operation, would you need to do any form of radiation? And the reason really is chordomas have a very high risk of coming back despite these operations. Because they're so intricately involved neuronal structures, it's very difficult to remove them in one piece. And even when you do remove them in one piece with no leftover tissue, the risk of it coming back is relatively pretty high. And so for that reason, radiation is generally recommended. It's also more easily controlled when you give radiation at the time of the first operation than if you try to give it in the event it does come back. So for that reason, we recommend it in the upfront setting. The reason we recommend a proton therapy for these tumors, and again, I just want to show these images. These are, again, just highlighting the surgical changes and the surgical hardware and the screws that were put in, and then obviously seeing the spinal cord here again down in the middle. But this is the radiation plan. And the reason radiation and proton radiation specifically is recommended for these tumors is because these tumors require very, very high doses of radiation treatments to control. On the order of 70 plus gray, kind of like the osteosarcoma case that we initially talked about. However, one of the very limiting structures around these regions is the spinal cord itself, because the spinal cord cannot take 70 gray without us putting the patient at undue risk of side effects. And because the spinal cord can only tolerate a much lower dose in these scenarios while we're trying to give much higher doses to an area right around the spinal cord, that sort of phenomenon of the Bragg peak and the minimal exit and the sharp fall off really help us tremendously in these scenarios to be able to give the doses that we need to make sure this tumor has the lowest chance of coming back while really trying to protect normal structures, including the spinal cord. And so in this case, we did elect to give 70.2 gray. We initially gave sort of a two-phased approach. We gave 50 gray first and then 19.8 gray second. And that's what's highlighted here. So this is the 50 gray initially to a much larger area to ensure that we cover all the areas that might have contaminated microscopic cells. And then 19.8 gray sort of comes down and really just focuses on the area that's at highest risk. And that's the area here where the tumor originally began, as you saw on the pre-surgery MRI. What I want to highlight here is the red is the volume that we tried to treat. And right here in this small circle is that spinal cord, as I showed you. You can see that they're basically touching one another, and you want to try to use that sharp fall off to be able to give the 70 gray, but then not get anything even close to 70 gray to this spinal cord here. The other point I want to highlight is not is the spinal cord the only organ that we're trying to spare. You can see that the amount of dose that's getting to the lungs, to the esophagus, which is this organ through which we eat and swallow, to the heart, which is here, and then to the rest of the body is all significantly much less than it would be with any form of X-rays or photon radiation. So thankfully, the patient did extremely well. Apart from, again, some mild redness on the back, really had no issues. And at this point has already had one MRI post-radiation and remains sort of tumor-free at this time point, and hope that continues. That's my case. Thank you very much.
Interesting case, Dr. Arpit. Just one question. What was the neurological status of the patient?
So the patient was developing back pain. The patient did also have some degree of neuropathy in the left extremity, but it was predominantly pain that was eliciting the symptoms here and sort of the diagnoses.
Dr. Akshay, as a surgeon, what is your opinion about when there are spinal tumors which are involving the cord? So the combined role, physical decompression, only radiotherapy.
Okay, thanks, Vivek. I think I'm audible. Yeah.
Yeah, you are audible.
Yeah. So basically, we look at two kinds of surgeries for bone cancer. One is a wide excision where you want to just sort of take the whole thing en bloc with wide margins without actually entering the tumor. And the second is when you want to debulk and take the tumor out in pieces and then try and take the whole thing out. And as Arpit just pointed out, this was not just touching the cord, but also pushing it to one side. And a complete removal, surgical removal in a single piece is not feasible in such situations. And that is where you are forced to do a piecemeal excision. And this obviously leads to spillage of tumor cells, and you cannot expect surgery to deliver very good results in the long run. And that is where I think therapies like proton therapy are going to be really useful. My question to Arpit and to Srinivas and also to Mudit and Matt is that we've been talking a bit about separation surgeries for spinal tumors with SBRT. Is proton going to remove the need for separation surgeries, or are they still relevant?
We can talk a little bit about that. I think that's an excellent point. Even with proton therapy, there is a limitation in how fast we can make the dose go from therapeutic dose to zero. Sorry, to be more clear, not fast, but over a certain amount of distance.
Yeah.
Right. So the distance is certainly shorter with proton therapy than with photon therapy like VMAT. But if there's tumor abutting the spinal cord, we cannot make it go from therapeutic dose to zero dose with no space. So I think there will always be a role for surgery in that sense.
Okay, so if I may ask, in this situation, yeah, please.
I was going to add one thing that we should clarify is when we're discussing separation surgery and spine SBRT, we're not talking about it in a primary chordoma setting. So that's typically talked about for a bone metastasis, which you're giving. Yeah, so in this specific case that we've been discussing, it would not come into play because SBRT is not an established treatment for chordoma. But like Dr. Spraker said, we want to make sure that the dose fall off is not in the spinal cord itself. And so the separation surgery allows us to have more confidence with that.
So Dr. Akshay, we do, we don't call it as separation surgery, but we call them as decompressive surgeries. We have done a few cases of clival chordomas where there is significant brainstem compression. So kind of the surgeon goes in and decompresses a portion of chordoma, which is into the prepontine cistern, pushing away the brainstem. Even in the situations, rarely in cervical or dorsal chordomas, wherever we see, when it is pushing pleura away, cord away, some kind of a decompressive surgery. Of course, the surgeries can be done in toto, massive, as you widely mentioned, the wide excision is definitely preferred. But we do this kind of separation surgeries in situations where they are massive and we are not able to do a complete excision, and there is a brainstem organ compression or a pushing away, and we try to do because as Dr. Matt mentioned, whatever you use, whether you use proton or X-rays, you do still need some separation from the OAR. Despite proton, you will never be able to achieve the kind of doses which you want to achieve, especially in tumors such as chordomas.
Yeah, so as a surgeon, see the basic difference that a surgeon feels is there between a decompression, a complete gross complete excision, and a separation surgery is that if the radiation oncologist tells me that if you just remove the tumor that is just next to the cord, I'll take care of the rest of it, because I can deliver good dose there. And where ultimately you are going to depend only on proton therapy, you would be better off taking tumor which is just next to the cord, and then maybe you could have avoided a corpectomy here. My question was pertaining to whether you would still prefer a complete corpectomy and gross total removal even with proton, or you would be happy just the tumor next to the cord being removed.
Dr. Akshay, I would be happy to send it to my surgeon on any day for any chordomas, any sarcomas. As you rightly said, surgery is the key. There's no doubt about it. And we irradiate in a post-operative situation for a microscopic disease, the outcomes are going to be definitely better compared to irradiating a gross tumor. So whether it's a clival or the dorsal or a cervical or any spinal chordomas, I would always push for surgery if feasible, whatever surgery is feasible. Of course, In sarcomas, R1 or R0 resections are definitely very commonly practiced, but for chordomas, it's very challenging, as you know. So I would accept an R2 resection in chordomas, but always surgery is the key. There's no doubt about it.
I just want to add to that, so not to get too technical here, but actually many studies have looked at the outcomes of chordomas getting proton radiotherapy and how much tumor was there at the time that the proton started. It's been shown that the smaller the amount of tumor that's there is significantly better than the larger amounts. And that's not just because the space is more from normal cord or brainstem and how much dose you can give, but it's just a sheer function of the less cancer cells you have in an area that you are treating, the higher the likelihood you're going to do better. So for any situation, as you alluded to, Dr. Srivanas alluded to, not only do we want the surgeon to help us give us some space, but at the same time, we want the surgeon to help us to try to get as much of it out as it safely can.
Great, thank you.